Assalamualaikum doctors. In this video, I am discussing a video station. It also comes on history, that is idiopathic thrombocytopenic purpura (ITP). In ITP, we can be find like the child is showing patchy, bruising, purpura. Look at the pictures of three. These pictures on the body and whole body, And other symptoms include bleeding from the nose and gums, black blister in the mouth, heavy menstruational period, and fatigue. So this is ITP features patichi, purpura and bruising. I can see this is. So what are the differential diagnoses we can keep? Idiopathic thrombocytopenic purpura. We can keep like non-accidental injury, leukemia, henosclein purpura, any drug reaction, meningococcemia, anaphylaxis, sepsis and DIC. So history as usual, onset, course and durations, what make it better and what make it worse. Is it preceding by the any upper respiratory infections? Very important. And the rash, distribution of the rash, is this blanchable or non-blanchable? Rash, is there any oozing, pus, itchiness, painful or painless? Then we are going for headache, other orificial bleeding, and the red spots in the mucous membrane or eye, signs of suggestive of malignancy. Other family members, if registered to the social service. So we keep ITP on first DD. So as usual ITP, we are asking that first preceding any upper respiratory infections and any other site of bleeding like mucous bleeding, teeth, gums. So ITP supporting this history. Non-accidental injury, if we find, then we can ask like the family registered to social service, anyone threatening safety in the home. 2, 3 henosclein purpura we keep. So the distribution of the rash is very important, we know. That is buttock and lower leg. Then we are going leukemia. So leukemia, DD we keep as petici purpura present. We can tell that any hepatomegaly, splenomegaly, weight loss, abdominal distension. These are the feature leukemia. Then we go drug reactions, so any drug taken or not, anaphylaxis and allergy, sting bite, meningococcemia, so headache, fever, neck stiffness. These are, we will take the history. Now, what are the investigations we do? Suppose it is a case of idiopathic thrombocytopenic purpura, ITP. So full blood count, okay? Full blood count, coagulation profile, blood grouping, blood film and virology screening, bone marrow if suspect malignancy, and CT brain if neurological symptoms. So there is petici purpura and bleeding. So blood grouping, blood crossing. Blood grouping, blood crossing. Then I want to tell that blood film is coagulation profile, full blood count, virology screening, CT scan if neurological or MRI neurological any features, and bone marrow if suspected any malignancy. Now ITP treatment, what we do? So first of all, if there is only petici, no bleeding, then reassurance. Mild, we are giving tranexamic acid. It is an antifibrinolytic and adjuvant treatment to control bleeding. Mild, we are what giving? Mild, we are giving tranexamic acid. Now going to moderate. Moderate, we are giving prednisolone and IV immunoglobulin. Prednisolone and IV immunoglobulin. Severe, we are giving platelet transfusion, methylprednisolone and IV immunoglobulin. If chronic ITP, then bone marrow transplantations, prednisolone or dexamethasone, IV immunoglobulin, rituximab or thrombopoietin receptor antagonist, and splenectomy plus advice. So ITP management, we understand if there is only petici, there is no bleeding from any other orifice. So we reassure that patient. Mild, we are giving only tranexamic acid. Moderate, we are giving prednisolone and IV immunoglobulin. And severe, we are giving prednisolone, IV immunoglobulin and bone marrow platelet transfusion with severe. Chronic ITP, we are giving bone marrow transplantations, IV immunoglobulin, prednisolone, these are, and rituximab or thrombopoietin receptor antagonist and advice. Splenectomy advice. What are the advice we give? First, avoid contact sports, avoid NSAID. Steroid card bracelet. Educate them that it can be recurrent in 20% cases. So avoid sports, avoid NSAID, wear bracelet, wear steroid card, and it can be recurrent in 20% cases. So example, some exam questions are non-blanchable rash in full blood count and blood film. What finding? Abnormal differentiations, indication of bone marrow. Why not NAI? So why not NAI? NAI self-injury. NAI non-accidental injury. There is some different pattern of non-accidental injury. Non-accidental injury, the child look poor, unclean, unhygienic. There is no preceding any upper respiratory infection. That is very strong for ITP. Okay. They are telling what is the indication of bone marrow transplantation. So severe pallor, neutropenia, hepatosplenomegaly, lymphadenopathy, limb pain, splenectomy when we do massive bleeding, chronic ITP if medical treatment is failed, and hematology vaccination is needed. So splenectomy we do if chronic bleeding not improving after medical treatment, and vaccination after splenectomy is needed. We know this is all about ITP video station. It also comes on history. Thank you.